Okay, so this video is going to talk about the physician labor market. We're going to talk about a physician or a doctor's career, but in a very economics perspective. So the outline is that we're going to talk about the training of physicians from the perspective of medical school, residency, return to medical training, work hours, and barriers to entry. And we are also going to shift the role of physician a little bit, but talk about physician as an agent and from the perspective of agency economics. We're going to talk about physician-induced demand instead of health-induced demand. And we're also going to talk about discrimination during the practice of physicians. So let's get started. First, the training of physicians. We know that the first step for becoming a physician is going to medical school. Entry into medical school is very competitive and selective worldwide. In the United States, on average, 50% of the applicants gets accepted into at least one schools. And in some top programs like the UCSF, only 150 slots for almost 7,000 applicants. Another characteristic of medical schools is that the length of medical school varies across country. In US or Canada, applicants must have their bachelor's degrees before they enter the medical school, versus in Europe, applicants can go directly from high school. They can get a bachelor degree and then a doctorate degree in medicine. Medical schools are usually super expensive. This number is from a few years ago, that it costs on average $140K to $225K for 4 years of medical school. In Europe, medical training is often heavily subsidized. So we think of subsidy, we always think of where is the benefit goes to. If the benefit goes to both this person who is getting the degree and the society, then we should not just let this person alone carry all the cost. The society should carry some of that cost as well. We call that positive externality. And when we identify positive externalities, we provide subsidy. That's the logic behind subsidization. So this is not the case in US. Most of the costs, let's say tuition, is bared solely on the person who is getting the degree. The next step after medical school is residency. So in addition to classroom work, physicians in training must also gain hospital experience. Residency is a period of on-the-job training following medical school. New residents usually lack experience, and when new residents arrive at the hospital, there are empirical evidence that medical errors will go up. In the US, we call that July effects, that counties with teaching hospitals experience a 10% increase in fatal medication errors in July. In UK, they call that August killing season. Another thing about physician is that they have extra long work hours, usually over 60 hours a week, some of them up to 80. On-call residents could work up to 30 consecutive hours. So in 2003, there's an implementation to limit numbers of hours per week for US doctors. So this policy says that doctors cannot work more than 80 hours a week or 24 hours in a row. They find that before and after this policy, there isn't a significant change in patient mortality. Why is that? Some people think that it may not be effective. This policy may be there, but some residents still works over 80 hours a week, but just report 80 hours. So why is there such a long hour? There's actually a trade-off of longer and shorter hours. For longer work hours, physicians or residents get tired, and fatigue may impair physician cognitive abilities and in turn may affect patients' health. While if we limit the working hours and make it shorter, it actually requires more handoffs by physicians, and thus there's also a greater chance for an error. For example, if we need two nurse or physicians to take care of one patient, now we split this into 3 different persons, one after another. And this time to hand off from the first physician to the second one, or from the first nurse to the second one, might increase the chance of errors. So it is an empirical question that which effects dominates, so that we can find the best hours of work that limits the harm or limits the error. So here you go. We have our randomized controlled trial, or RCT. So this experiment is ran in women's ICU at Harvard in 2004. They have, of course, treatment and control group. Control group is traditional hours, 80 hours per week. Treatment is the short work week, so 60 hours per week. So we find out that comparing treatment and control, the traditional hour group committed 36% more serious medical errors, 21% more medication errors, 5.6 times more diagnostic errors. Okay, that's 560%. Okay, and senior physicians intercepted most serious hours. Okay. So now we're going to talk about returns to medical training. In terms of return, we're first going to focus on the income return. Okay, so unlike most occupations, return to medical training are very backloaded. Medical schools and residency is expensive, indirect costs and opportunity costs that you spend a lot of money on getting the tuition, or you take a huge student loan, and you have many years working in a relatively lower salary as a resident. And then after that, you can finally earn money as enough money as a physician. So those who choose to become physicians are often more patient, or they're patient enough to value their future returns. So here we have a graph that plots the time and income for a server. The income is positive, and it's gonna slowly increase and then decrease over time. Okay, so this time is in terms of a lifespan. Think of it as from age 18 all the way to age 65, let's say. Versus a physician, we can see that at time period, the first time period, the income is actually A, which is a negative value. So A is, let's say, the money you have to put into, the money you spend on living way, on just getting all the training and tuition. Okay, and then moving on to the second period, you earn a positive wage, which is still lower than the server. This B is, let's say, the wage when you are a resident. And then after time T, let's say it's age 30. After age 30, or maybe above that, then you become a physician. Then your income level is C. So C is a slowly increase a curve because there is a return of experience. So wages as a physician slowly increases over time, and it keeps increasing even though you're getting older. Okay. So how do we measure that? How do we measure this time preference, or how do we measure this level of patience of a person? So here we introduce, so here we first introduce the first concept called net present value. Net present value is a way of calculating the value of all future streams of income from today's perspective. So we are not just going to add up all of our future income one by one in dollar wise, but instead we're going to look at it in today's perspective. Think of how much $1 you earn in 10 years value or is important to you today. So net present value is the summing up delta to the power of t times the income of time t. I'm going to add that from time from 0, which is, let's say, when you're 18-year-old, to capitalized T, which is, let's say, the last year that you earn income. Okay, so this delta, this count factor, is a measure of how much less an individual values future income over present income. Delta lies between 0 and 1. It is small if a person is impatient. Okay, that means if delta is small, then $1 tomorrow worth less today. It is large if a person is patient. That means tomorrow's money is worth more in today. So those with high delta has high net present value from being a physician, versus those with low delta has low net present value from being a physician. Or maybe it could be even negative, okay? Because the first period of being a physician is negative. The income is negative because you have to spend money on getting the degree. Okay. So theta equals to 1 over 1 plus r. Here we have another term called discount rate. I would like to point out that discount rate and discount factor are just two sides of one coin. They measure the same thing, which is how patient a person is. But when we're doing a calculation, they look different. So it's important to realize that. For example, if a person's discount factor is 0.9, then this person's discount rate is 0.11. Okay, and the conversion equation here is here on the slides. So very patient person should have a very high delta, but have a very low discount rate, R. All right, so when do people have an indifferent choice between being a server and being a physician? We call that rate internal rate of return. So if your R equals to R star, which is the internal rate of return, then you're indifferent between choosing these two different career because they have the same net present value. Okay, so we have to solve an equation of net present value of being a physician equals to net present value equals to being a server. And then we solve the R star, which equates them. Okay. All right, so the next graph can explain that even better. So a person's discount rate, R, is between 0 and 1. And if R is larger than R star, which is the internal rate of return that makes it indifferent between two choices, then this person is impatient and he is gonna choose serving. I do believe that there's typo here. Okay, let me point that out. I think it's actually impatient. Okay. Right. It's not patient, or instead of inpatient, which means you're hospitalized. Okay. But if your discount rate is smaller than internal rate of return, which is R star, then you are seen as a patient person and you will choose the career of being a physician or choose medicine. Okay. All right. Okay. All right. Okay, so some more things about internal rate of return. That is, the R star here is typically between 11% to 14%, and this is significantly higher than market interest rate, which means that market interest rate thinks that you will choose this career if you are under that, the internal rate of return, while the internal rate of return for medicine is way higher than that. That means a lot more people will be under this 11 or 14%. Okay, so then why not we have a lot more people choosing the career of being a physician or dentist and lawyer or medical specialist like neurosurgeons or immunologists. Okay, so the problem is that internal rate of return has stayed high, but not many people are becoming doctors. And we believe that it's not just because of whether you're patients or not. It could be whether it is difficult to get into this field. Okay, so we think of that as barriers of entry. Okay. So let's say if everyone is patient enough to choose physician, why not more people become a physician? And the problem of that is lots of people just can't get into it. Let's say in 19th century, becoming a doctor was simple. Anyone could do it, no regulation about the training. But since 1847, there is a lot of prerequisites for medical school. There are 4 years of medical school. It is not always easy to get student loans about it. It requires doctors to have a license to practice. And in 1910, there's a report that shut down a lot of low quality medical schools. So we find out that there are much less medical schools and much less medical students. A lot of schools capped the size of medical school class. Doctors need license to practice on their own. International medical graduates, for them, there's a long and arduous process to practice in the United States. And 40% of those who apply for license do not succeed. For nurses and physician assistant, there is a limited in scope of practice. And for alternative medicine, they need a license too. So even though a lot of people are patient enough to decide on getting a career in being in becoming a physician, but the barriers of entry has kept the number or the supply of physician low enough for us. Okay. All right. So because of that the limited supply of physicians or barriers to entry, consumers end up worse off because consumers have to pay above the competitive price to get physician care. And therefore, physicians can earn monopoly rents. They earn it not just because they are super highly educated for that, but also because there are not enough physicians, so they can charge higher for people who really want it. We know that barriers to entry ensures that physicians are qualified or good enough so that we can trust them. But the downside of that is not having enough of them, and the price is driven up. Okay. So then the next part, we want to think of physician as an agent to shift our mind a little bit. So agent economics happens when there is a different players, but these players do not necessarily have the same incentive. So for example, when we go to a doctor, we trust the physician enough that we hope them can act in our best interest, which is our health. So we think of them as perfect agents. They are perfect because they have the same incentive with us. Instead of thinking about their own financial status or reputation. But the problem is our doctors are always perfect agents for our health. So that depends when it comes to how the system, how the physician payment or reputation system is designed. One thing that we want to point out is that there is asymmetric information between doctors and the patients. The patients usually don't know how to treat themselves. The doctors know. So when the doctors do something, patients have no idea how to assess whether this extra test or procedure or extra medicines ordered by the doctor is necessary. If these are financial incentives for doctors, they will tend to prescribe more services than needed because they can get more payoff by doing so. And we have found a lot of empirical evidence that when the reimbursement rates for various procedures changes, the doctor's prescription practice will also change. Okay, so here you go, randomized control trial again. There are two groups, control and treatment. Think of here, the salaried one is control, versus the fee-for-service is a treatment group. So in a fee-for-service group, doctors will get more income if there are more visits scheduled by the patients. Okay, so they find out that in this randomized control trial, orthopedics and neurologists who own MRI machines will order more MRI tests because that will increase their income. Another perspective of these different practice incentive is called defensive medicine. This is a very unique, or this is more obvious in United States, where overutilization of testing and services can protect physicians against malpractice lawsuits. So if doctors are if there are more people suing doctors in the country, then the doctors will become fearful of lawsuits, and so they would try to overprescribe, overcharge for only marginally useful procedures, so that they make sure they've done enough in order not to get sued. But these practices could be unnecessary, or it could be just for the sake of being defensive. Between 1991 and 2005, 7.4% of physicians faced at least one malpractice claim. Okay, so this is relatively a higher percentage comparing to a lot of other countries. A paper in 2010 estimate that medical liability system in the US cost 55.6 billion annually. And these monies are spent for the sake of not getting sued. Okay, the next part we want to mention is discrimination. Racial discrimination can be very direct. or obvious, or it could be a little bit less obvious and requires empirical studies to figure that out. So there are different type of discriminations that's defined by economics. There is taste-based and statistical. Okay, taste-based is what we call is what we think of racism in usual terms, that we don't like a certain kind of race, so that's a taste-based racial discrimination. So for example, some doctors, if they are racist, if they discriminate, racial discriminating, they prefer to treat some group of patients, or they have a preferential treatment for certain groups of patients, whether it's conscious or unconscious. Another type of discrimination is called statistical. So they generalized rules or trends in different ways, that, for example, they think that if certain groups of patients usually have a certain type of disease or get certain type of treatment, then they use that when a new patient comes in and this patient falls into that group. But instead of really take a closer look at the problems of this specific patients. Okay, so statistical discrimination will focus more on stereotypes, on biology or behavioral tendencies. Okay, so discrimination can sometimes be efficient if you just use a more efficient way. If you just focus on stereotypes of some type of tendencies, it could be informational sometimes, but a lot of times it is inefficient because it will harm patients. Okay, even though some others may benefit them. So let's take a look at some evidence of discrimination. In 1999, there is an audit study that focused on fictional patient histories. We have Black and white actors. Patients will tell doctors the same script, background, and hair emotions, and the only differences is their skin color, okay, or the race of the patients or the actors. Okay, so these actors will tell exactly the same thing. Okay, so making sure that the control group and treatment groups is the same, and the only difference is their race. The study finds out that physicians are less likely to recommend standard treatment when the actor was Black. Okay, so the problem is this taste-based discrimination or statistical discrimination? Is this efficient or inefficient discrimination? Okay, so taste-based is always inefficient because it comes from some conscious or unconscious belief from the physician, and it's a physician side difference. It has nothing to do with the patient. And so patients is always worse off when the physician has their own idea, right? The second part is statistical discrimination can be efficient. And it is efficient if the medical evidence to treat racial group differently is actually helpful. So for example, optimal hypertension treatment is different for Blacks than for the whites. So if a doctor treats a patient optimal hypertension based on the tendencies between these two groups, and this could be helpful because some groups can have a certain tendency of some medical let's say diagnosis or conditions, and this statistical discrimination can benefit that. Okay, so in conclusion, physician supply is highly regulated. This leads to a shortage of doctors. But on the other hand, it makes becoming a doctor very, very attractive in terms of a career. It could be hard for other healthcare providers to fill the void. Secondly, investment returns to being a doctor and specializing in a certain field is very high. We also mentioned physician practice. So physicians are not always the perfect agents of care. They can react to incentives and have and results in overutilization of care. Physician-induced demand and defensive medicine is common in the United States. Lastly, racial discrimination is also common in the current system, and it always requires careful empirical work to identify them and to know whether they are efficient or not. Okay.